I think we're live here, so let's go ahead and get started. Welcome, and thank you everybody for joining us for today's session, Frequently Asked Questions on Multiple Myeloma Highlights from the International Myeloma Society meeting Livestream. My name is Dr. Christopher Pena, and I'm the Director of Educational Programs at the MMRF. And today I am joined by Dr. Jesus Berdeja from Tennessee Oncology in Nashville, and Dr. Keith Steweart from the University of Toronto in Ontario, Canada. So recently, about 2 weeks ago, we hosted a webinar on the IMS meeting highlights, and today's live stream is going to be a continuation of that discussion with more opportunity to answer your questions live. So we got some of your questions from that webinar, and we're also going to have some today, and we're going to do our very best to weave them into the discussion and try to get the answers that you're looking for. As far as the webinar goes, you can find a link to that recording under the Education Resource Hub on our website at themmrf.org. And any listener should feel free to start submitting your questions in the live stream chat. So today's agenda, just briefly, and again, we're going to weave questions in and out of this, but we'll start by understanding a little bit more on the clinical trials that are really behind these IMS highlights. And then we'll discuss important findings for newly diagnosed patients. And then lastly, relapse refractory patients. So great agenda today, and I'm happy to go ahead and get started. So kicking this off, we saw information from clinical trials at IMS. And before we get to the findings on those, Dr. Berdeja, would you mind giving our listeners just a brief overview of clinical trials, for example, the phases and how patients are typically recruited?
Yeah, absolutely. And thank you for having me. This is always a lot of fun for me. And Dr. Steweart, thank you for hosting the last IMS meeting. It was fantastic. Toronto was a great surprise. I had never been there, so thank you. That was excellent. But so clinical trials, are basically how drugs go from the Dr. Keith Stewart's laboratory to approval. So basically, a laboratory sees a compound that looks very promising, is tested in the laboratory, is tested in animals, and it seems to be safe. So the first time that drug then is brought in to be tested in humans to see how safe it is and to try and find the dose, that is called the phase 1 clinical trial. And it's usually patients who have exhausted all available treatments who tend to join those kind of trials. If the drug then looks promising there, and there's a dose that's identified that looks to have activity, then that moves on to the phase 2 trial. And at that point, we're trying to really assess, how efficacious this drug is. The drug then usually goes on to a phase 3 trial, and that is really the proof that is required to show that this drug is superior to something that we already have. And that is often how a drug becomes FDA approved. There are some drugs that are so novel, that look so promising, just like, for example, some of the CAR T therapies that often can get approval in the phase 2 setting and sometimes even in the phase 1 setting. But that's usually the exception.
And that's a really terrific overview, distinguishing between the phase 1, phase 2, and phase 3 clinical trials. Dr. Steweart, one thing that a lot of people have questions about is really, how do we measure if a clinical trial is working or not? What are some of those important parameters that can tell us if something is, if that has good efficacy or if there's good safety to it?
Yeah. Well, let me focus not on phase 1, because that's really just, as Jesus said, about determining some very early effects of the drug. What for approval we're really looking at is efficacy and safety. And efficacy can be measured a number of ways. Traditionally, this would be the percentage of patients that respond to the drug. Increasingly, and today, because of the long survival of patients, we're now actually relying more and more on that as an early predictor of what long-term outcomes will look like, because it could take many years otherwise. And we're focused on something called minimal residual disease, which is how deep is the response, and can you get rid of all signs of myeloma as a marker, because we know that translates into longer-term outcomes. Other things the trials will look at are progression-free survival. This is how long after you start the drug it takes until your disease relapses, if ever. And then, of course, overall survival, which is the penultimate measure of success, of course. How long do people who take the drug do? And how does that compare to historical norms or to the control arm of a study, which is usually something we're using in the clinic today. So I would say those are the three main things for efficacy: depth of response, frequency of response, depth of response, time till your myeloma comes back, and how long you live with your disease. And then on the safety side, of course, we're quite interested, and we may talk about this later in the modern drug era, in is this a safe drug to use given the benefits that one can derive? So that's a whole other kettle of fish.
And just to follow up, if a trial is successful, so we're seeing excellent progression-free survival, we're seeing some really promising safety outcomes, how long before that treatment actually gets to patients?
Well, it depends very much on the jurisdiction that you live in. Usually in the world, the USA is the first jurisdiction to get approval for these drugs. So when the company, as soon as they have their trial results, they're usually very quickly going to the FDA to meet with them, discuss this, asking for a review of the data and approval. And in the United States, just correct me if I'm wrong, once the FDA gives approval, basically by law, the insurance companies and Medicare must pay for the drug. Outside of the United States, it is very different from country to country, but in many countries, there is an additional step after approval. So they have to come to each country and get approval by the regulators in each country. And once that happens, there's often a third decision, which is the country willing to pay for it? Particularly in public health, are insurance companies willing to pay for it, or is the public purse willing to pay for it? And that can actually be quite a slow process in many countries. Canada is one of the worst, to be quite frank, in terms of how long it takes to decide if a drug will be paid for or not.
And that's a helpful explanation. I think we're looking at that from the release standpoint, and might have jumped a little bit earlier, or a little bit late, I should say, into this part of the conversation. But in terms of eligibility, so somebody looking to join a clinical trial, there's definitely questions around that and around certain terms like line of therapy. And I know we use that word a lot when we're describing some of these trials for patients that have had, let's say, 2 to 4 lines of therapy or something like that. Dr. Berdeja, can you explain what line of therapy means and just provide a brief example of that?
Yeah, sure. So just to kind of comment on what Keith said, though, I think in general, it's going to take about a decade, right, for a drug to go from the initial testing to actual approval. If we're lucky, maybe 5 years with some of these really novel therapies. But the best way to get access to these drugs is to join a clinical trial. So, for example, I had patients who got what's now called Carvykti 8 years ago on the clinical trial. So clinical trials are a great option for patients. And usually trials are divided into newly diagnosed, early relapse, or relapse refractory. And so the newly diagnosed, obviously patients have never had any treatment for the myeloma. And so that's the requirement to go on those trials. The early relapse trials usually are 1 to 3 prior lines of therapy. So a line of therapy is when a patient gets treatment, and then the treatment either stops or continues because the disease progresses on the treatment, or the treatment stops and then the disease progresses later on. That is considered a line of therapy. So the number of treatments that you give for each relapse is the easiest way to remember. So if your disease has come back twice, you've had 2 prior lines of treatment and you're going on to your third. One of the things that often gets confused is when patients go through transplant, where they get an induction treatment and then they go out of transplant and then go to maintenance. And it seems like that should be 3 lines of therapy, but that's actually considered 1 line of therapy because the disease never relapses in between the treatments. So that would be considered 1 line of treatment. When the disease comes back, then that would be the 2nd line.
Right. That's really helpful context going into how we're going to describe some of these next clinical trials that we'll talk about, especially when we get more to relapse refractory. So thanks for that explanation. Looking at newly diagnosed. So let's go and start with that. So for newly diagnosed patients starting therapy, they're often given a CD38 monoclonal antibody like Darzalex or Sarclisa. Right now, these options are limited to subcutaneous administration of Darzalex or IV administration of Sarclisa. So one study in particular actually looked at an improved way to administer Sarclisa. So Dr. Steweart, if you want to take the lead, can you tell us a little bit more about this particular study and what it means for patients?
Yeah, so Sarclisa, of course, has the disadvantage compared to Darzalex. There's an intravenous delivery. And so the company, recognizing that, has developed a very technology advanced solution, actually, which is an on-body apparatus, which can be theoretically at least, administered by the patient or a nurse in their home. It's attached to the body. You press a button, it injects under the skin within a few minutes, the Sarclisa. And this, of course, would, at least in theory, allow patients to stay at home, not have to come into the clinic and spend hours in a chair, and of course make it more comparable to Darzalex. So that's what the technology is. The study that was reported at the meeting was a phase 2 trial. So basically it was asking the question, is this as good as the historical results we get with the intravenous form? And the answer is yes. They seem somewhat indistinguishable in terms of the delivery methodology. And what the issues are now, they have to go to the FDA to get approval for this different, administrative route. And then I think there's, for different cancer centers, it will be different as to whether they still need the patient to come in, whether they can deliver the drug in the home setting. And that's probably different by hospital, by state, and by country in terms of how the system is built around that to make it work. But it certainly will make it a more pleasant experience for patients. I don't know, Jesus wants to add anything to that.
Yeah, no, I agree. And I think it's going to depend also on the partner, right? So if all of the other drugs, none of them are IV, I think that's where it really becomes a big asset. But if you're pairing with something like Kyprolis, which is IV, sometimes, if they're both IV, it may not be as big of an issue. But I think from what we've seen, right, Keith, with Darzalex, definitely the sub-Q has taken over. It's rare that I see IV Darzalex anymore. But it's similar to the same.
Yeah, go ahead. Sorry, Chris.
Oh, no, go. I was going to say, it's funny, we talk a lot about this from the patient side, and sometimes we have allied health providers listening in, or sometimes nursing oncologists. So from their perspective, do you see this improving anything as far as the actual people administering it?
Well, you don't need to establish intravenous access every time. Presumably people will have, if they have a PICC line, or there's also a little bit of an increased risk of thrombosis, of clot in the vein. There's some risk of infection. So I think there's advantages. One thing that does worry me a little bit is it's a simple device, but it does require a little bit of training. And, because our nurses change shift, they change frequently, they move around. It's just a lot of ongoing training for people, but not insurmountable for sure. And I think it will be an advance.
Great. And so that, that's something that I think patients can look forward to. And in terms of just the available options now, if there is no ESA sub-Q available, are there any studies out there that show ESA IV or ESA plus VRD is still a good option?
Well, 100%. I mean, the results, honestly, pharma doesn't like to hear this, but I think for most of us oncologists, we consider the two drugs to be basically the same. So it's really just an issue of what's been approved by the regulators. Presumably over time, there might be some cost differentials that get into the thing. But for all intents and purposes, adding one of those drugs to the traditional backbone of Revlimid and Velcade and dexamethasone works extremely well in all circumstances, both those going to transplant and those who are not going to transplant. So that the use of all four drugs together has really become a standard in newly diagnosed patients.
And then has there been any studies looking in the relapse population as well?
Jesus, do you want to take that one?
The answer is yes. So again, this is not a new drug, right? This is a drug that's been around for a while. So when we talk about Darzalex or isatuximab, these are both anti-CD38 antibodies, and both of them have been tested. Initially, were tested in the relapse refractory setting, and again in relapse combinations with multiple combinations, the usual partners with pomalidomide, with Kyprolis, and then they came to the newly diagnosed with what Keith Steweart just mentioned with the 4-drug combination. So absolutely, there's a lot of very good data with either of the anti-CD38 antibody in both in the relapse refractory setting as well. So yes, I think the main issue now is sort of this new formulation. I think it's something that kind of held the drug back a little bit, especially in the United States. There was a lot more use of the subcutaneous dosing of Darzalex, and so I think now this is allowing them to sort of kind of try and catch up. And theoretically, if it's easier, may even help them, right? Because we all get these horror stories with Darzalex, where the patient and the nurse sit there for 5 minutes, giving this drug very, very slowly, and it's a large volume. So if this becomes much easier, I think that's just really more about just sort of kind of how much easier can it be. But in terms of efficacy, it's very well established.
Well, that's great. And so if a patient is coming to you asking to weigh these two options, what would your overall advice to them be?
I would be either is fine, and I wouldn't worry about having to specifically ask for one or the other. And it comes down to, again, I think both what the doctor and the patient and the staff are used to. I mean, like Dr. Steweart said, we really don't think there's much difference between the two antibodies.
Great. Awesome. Well, I think we can shift gears and talk a little bit about something newer now. So the cell mods. So these are a new class of treatment, and they're showing a lot of therapeutic potential, especially in the newly diagnosed population. These are also oral agents, which can address some of the more logistical challenges of IV therapies and so on and so forth. So, Dr. Berdeja, can you explain, exactly what is the cell mod and what have really the latest trial with the cell mod iberdomide showed?
Yeah, so the cell mods are a new class, but they're very similar to the old IMiDs, right? So your Revlimid and your Pomalyst are in the same class. When Revlimid, Pomalyst, thalidomide were first introduced, we didn't know how they worked, and then we found out that it actually worked through inhibiting this drug called cereblon. And so now these new group of drugs is designed specifically to inhibit cereblon. So they're much more potent at doing so, and they're much more specific. So they potentially, theoretically, have less potential to cause issues outside of targeting that molecule. And we are actually seeing that in the studies, that maybe some of the side effects that we see with Revlimid, like diarrhea, fatigue, rashes, are not as common with this new group of drugs. So that may actually be a big asset for them. But that's basically what these are. So these are drugs would be sort of the potential next generation or replacement of that class of drugs. And so yes, so at the IMS there was a small sort of the big cohort of iberdomide is this big trial that has a lot of arms where we're sort of testing different combinations. And this one combination that looks at patients who are treatment naive, meaning they haven't had any treatment, where they gave iberdomide, which is oral, with Darzalex and dexamethasone. So similar to, instead of Revlimid, we could use an iberdomide. And that looked fantastic. 75 patients, response rates of over 90%, and about 2/3 of the patients were MRD negative. So it looks very powerful. It looks very good. It was very well tolerated. The main side effect of iberdomide, and that's expected, is neutropenia. So low white blood cells, low neutrophils, because the neutrophils are actually also dependent on cereblon, which is what's being inhibited by the drug. Although most patients can be treated successfully with either drug holds or with the use of growth factors to stimulate the neutrophils.
And so we did have a question from somebody listening in, as far as cereblon goes. What is it that they inhibit? Can you elaborate a little bit more mechanistically how that happens?
Dr. Steweart. I can do it if you want.
Yeah,
He knows more.
The gene is called cereblon, and it's a way of the cells to degrade proteins that they don't want anymore and get rid of them. And actually what these drugs do is they enhance that capability so that it becomes even better at degrading and getting rid of proteins we don't want. And some of these proteins are very critical to myeloma cell survival. And so with the newer versions of the drug, they're almost 1,000 times better at doing that than thalidomide was, when we started using that, 25 years ago now. I'm really getting old. So Jesus was probably still in high school.
Right.
So anyway, that's how they work. They bind very specifically to this one protein. They help it get rid of the things that the myeloma cells need to survive. And the better they are at doing that, the more likely the myeloma cells are to die. And each progressive drug, from thalidomide to Revlimid to Pomalyst to now we have iberdomide, which is the one we're talking about, mezigdomide, and also a different way of, and people have learned how to actually capitalize on this and build their own degrading systems. And one of the drugs that was presented was sort of even better than the older ones in some ways. So, yeah.
So there's another clinical trial out there called the Excalibur trial, and it's looking at iberdomide, Darzalex, and dexamethasone, and comparing it to Darzalex, Velcade, and dexamethasone. So obviously we don't know the results of this study quite yet, but could iberdomide potentially replace something like Velcade?
So, so that's not the right way to look at phase 3 trials. So right now, iberdomide is not FDA approved. And so I think, it would have been FDA approved probably 10 years ago, would you say, Dr. Steweart? But now, because of the CAR Ts and bispecifics, the threshold for a single drug to be approved has become much higher, which is really unrealistic. So now we're dependent on sort of kind of doing these combination trials in a phase 3 setting to get the drug approved. And so that's the purpose of this study, really, is looking at the combination of Darzalex, iberdomide, and dexamethasone, comparing it to one of our standards of care, which is Darzalex with Velcade and Dex. And so assuming that the iberdomide arm wins, then that potentially can then go to the FDA with that data, and that can get us approval of this combination. But it wouldn't necessarily replace Velcade. Velcade can still be used in other combinations, and even in the front line, as we just talked about it with the quadruplet. But that would be a way to hopefully get iberdomide approved for myeloma patients.
No, thanks for clarifying that. I think that that's really important too, that just because we're switching these therapies in and out doesn't mean that they're going to be completely gone from the library or anything like that. It's about building this arsenal of therapies out there. So that's really important. One thing I want to get into now is, right now we're looking at quadruplet therapies such as Darzalex, Velcade, Revlimid, and dexamethasone as the standard for newly diagnosed patients. But there's some research that we saw at IMS where we're looking at the role of newer therapies like bispecifics in combination with other treatments. So Dr. Steweart, what could be the advantage of offering a bispecific therapy up front?
Well, bispecifics are ways to activate your own immune system to attack the cancer. They are profoundly active. They're really very exciting drugs. And there are some studies now that were presented at IMS, not the final results of the study, but early enough to get people excited and really quite remarkable. If you add a bispecific antibody there were 2 trials with 2 different bispecific antibodies to a sort of standard regimen, even I see somebody in the chat saying dexamethasone is a hard drug to take. So in these new studies, they're actually dropping the dexamethasone and just giving Darzalex, or in both of these trials, I believe, with a bispecific antibody and with I think they both had bortezomib as well. I remember earlier we talked about efficacy and safety. The efficacy is extraordinary. Like 100% of people responding with and having very deep, minimal residual disease negative responses. I think this is the future, quite honestly. I think we're going to be heading this direction once the trials are completed and they can go to the regulators with them. However, and we'll talk about this some more with CAR T. I see somebody else asking about that in the chat. There is a price to pay, and the price to pay is the infection risk is quite high. I think in one of the 2 studies, it was like 70% of people had an infection. Extraordinarily high risk of infection with these drugs. And when we're talking about survivals of myeloma patients now into the 15, 20-year range, you don't want to put people at such high risk in the first 6 months of their myeloma treatment. So I think this is something we really need to be a bit careful about and just make sure we understand either how to manage the infection risk, lower the doses, or cut the duration of treatment. But I think we've got to be just a little bit careful there in terms of not causing more harm than good in the early months of treatment. I don't know if Jesus wants to add anything to that.
I agree. I think this is probably the most exciting thing, one of the most exciting things that's happened in our field. But I think we do need to, I think there our ability to take on risk depends on when it's given. So like Dr. Steweart said, in the relapse refractory setting, when the patient doesn't have too many options, we're willing to take more risk potentially for benefit. But as you get earlier on, when the person is trying to get their disease under control and hopefully live a good life for many, many years, even decades, then that risk of an infection, cutting that life short, it becomes much more of an issue. So I completely agree. I think we are going to incorporate them the question becomes, we need to learn how to do it the safest. And what it's looking like is we're going to be looking at maybe doing just a very limited duration of that therapy to get that depth of response, and then maybe back off, which I think these drugs are able to do to help us do. But again, those trials are still ongoing, so we don't know exactly how to best use them. But I think they look fantastic in terms of just how well they work.
And from a practical standpoint, especially because this is a newly diagnosed setting and we're offering these bispecifics in the upfront, does that have any impact with step-up dosing and some of the other agents that other patients may be taking during that time? Is there any guidance for that?
I'm not sure I follow the question. You still have to do step-up dosing, and that's to reduce. It has been traditionally you had to be admitted to hospital to get these drugs because there's a risk of fever, low blood pressure, even neurologic complications in the first week. And so we start very low, then we go to medium, then we go to full dose. And now, but I think a lot of us now are managing to move that into the outpatient setting because we just didn't have enough beds in any hospitals to treat every myeloma patient for a week in a hospital. So I think that many of us, I'm sure Jesus is doing this too, have moved the bispecific antibody therapy into the outpatient treatment as best we can.
Right. The only caveat to that I would say is, there is a possibility, and there are some studies looking at this, where if you use the bispecific as consolidation, so maybe you start the treatment of the 4 drugs, you get the patient in remission, and then you give the bispecifics to get that deep remission. In that setting, when there's been studies with CAR Ts as well, we may not see the same degree of cytokine release in ICANS. That will make it so much easier, like Dr. Steweart said, in terms of giving this as an outpatient without those initial caveats. But it doesn't take away the infectious risk. But it may sort of kind of help significantly with some of these sort of acute toxicities that we see in the first step, which is why we require all these step-ups and observation in hospital sometimes.
And just kind of get into like the risk of infection. So we're having the balance between, using these bispecifics and the potential for risk versus patient need. Specifically, is there any certain patient population that this really would benefit a lot from? And so, in spite of that, you still kind of want to go forward despite the risk of infection.
I mean, I think, again, it's sort of kind of, there's a person that may have very high risk multiple myeloma, where we're really concerned that their disease is coming back very quickly with our current standard of care. That would be the person where we would, that both the patient and the doctor may want to take more risk. And so that risk is more acceptable, as opposed to someone who will do very well with our current standard of care, where again, the last thing we want to do is shorten their survival. So there are patient populations where the risk assessment is different. But at the end of the day, ultimately, is we just have to learn how to do this well and do appropriate preventive measures so that these infections are low-grade infections, that it's something that is not life-threatening.
I will say, Christopher, that people who on the bispecifics have to have, they need their vaccines up to date. They need to take medication to stop getting shingles, to stop getting parasitic infections in the lung, to stop getting other viral infections. And we've learned very quickly they also need to get replacement of their normal antibodies that we've sort of eradicated, because these drugs are so effective. They kill not just myeloma cells, they kill the normal cells that produce antibodies to fight infections. So we have to replace that artificially. The immune globulin, it's called, and it's given either weekly or monthly. And if any of the patients listening or are on a bispecific and they're not on immune globulin, you should talk to your doctor, because it's an important way of preventing infection.
Yeah.
But we actually just got a question in the chat about choosing among the available bispecifics. So, for example, Linvo, which is new, or something like Tecvayli. What would your advice be there?
They all look about the same, to be quite honest. They all about, depending on the types of patients they put in the study, somewhere between 50 and 70% response rates reported. Some of them even a bit higher if it's a small study with just a small number of patients. There may well be subtle differences between them, but without comparing them head to head, it's really hard to know. So I would say they're all good at this point. Any one of them would be worth trying. And it's often what your insurance will pay for or what's available that determines the disadvantages or advantages. There's also scheduling issues. Some of them are monthly, some of them are weekly. And that may be as important a factor as anything else.
So, Dr. Steweart, just kind of diving a little bit deeper into some of these findings from IMS here. So can you chat a little bit more about some of the findings? So we know that these are bispecific therapies up front. Can we talk a little bit more about what those studies were like?
The upfront studies or relapse studies? The upfront studies were really just taking, instead of giving the 4 drugs we talked about earlier, so one study was in transplant patients, one was in non-transplant patients, one was with teclistamab, one was with elranatamab, different companies. I think they both dropped the dexamethasone. And what we've learned so far was really quite short follow-up. Like, what was the results 6 months after a patient started, 9 months after the patient started the treatment? And all we really know right now is that they were, I think, 100% response, which is incredible. And that of those, I forget the actual number, but a good number of those were very, very deep responses, predicting for long survival, long outcomes. And they were capped. You didn't stay on them forever. There was a cap to how long, at least for the transplant patients, there was a cap to that. And I think that's also important because, and then the second thing we learned, of course, is that infection, at the time that these studies were done, probably before we were really in tune to all the prophylaxis you need, and after the COVID pandemic, which of course kind of messed up all the infection statistics, the infection was still still a fairly big issue.
Right.
But the bottom line is the trials will take another couple of years, I think, to mature, maybe even longer if survival is one of the outcomes. But I think we are excited about it. And I think if there are clinical trials, if you're a newly diagnosed patient and there are clinical trials available to you, this would be an interesting one to participate in. And at relapse, these drugs are they're sort of in the end stages of trials now for first or second relapse to see if they're better than the standard of care. They're mostly approved right now for late stages of disease. But those trials are well underway. They'll probably, again, take a year or two to come to fruition, but presumably we'll be using these drugs earlier than we do today.
And so earlier you had mentioned just about in the newly diagnosed population, some of these patients they were transplant ineligible or didn't get a transplant. So just looking at how effective some of these bispecific treatments are, would love for both of you to weigh in to see, are we heading somewhere where we don't need ASCT anymore because we have such powerful therapies up front? Would just love to get your thoughts on that.
You just decided to ask that little simple question, huh? Just out of left field. No, that is a big question, right? So absolutely, as we get better, the transplant's always questioned. This has been happening for many, many years, right? So each time we get a new combination, we say, oh my God, this is it. We're not going to need transplant. And then usually when the studies are done, transplant still induces deeper remission. So there's a benefit. But yeah, we're getting to a level where, like, Keith said, we're getting with quadruplet therapy, with incorporating bispecifics, we're getting 100% response rate and 100% MRD negativity. In that setting, I think there's that question arises. We had that French study called the MIDAS study, which actually looked at specifically at patients who reached MRD negativity before transplant. And those that were MRD negative went on to receive transplant versus the no randomized to transplant versus no transplant and just continuing the chemotherapy. And there seemed to be no benefit to transplant. But again, that was early, right? So we don't have the long-term results from that. So we can't say you can exclude transplant. But it's the first inkling that we're getting that maybe there's a depth of remission that can be reached where we're adding more therapy to get the deeper remission may not be necessary. But I think that we still have a lot of data to go through in time to kind of help us determine that fully.
Christopher, I see people in a lot of questions we asked in the chat we haven't addressed. I think we'll kind of come to them. We wanted to cover the new adventures we learned about at the meeting, and then we'll maybe come back to you, Lawrence, and others on some of the questions in the chat later.
For sure. Actually, so we since we are talking about MRD and just and some of these ways of deep responses and everything like that, we did get this question about an abnormal protein test ever going to 0 for somebody on Pomalyst. So just out of curiosity, have you ever seen something like that And if you can compare just looking at M protein versus MRD, and for people who may not be as familiar with MRD, if you can explain what the difference between these two tests are and what they mean for patients, especially in the context of some of these clinical trials, I think that would be helpful.
That's like 6 questions, Christopher. But, okay, so just I want to address Lawrence's question here in the chat. It depends what you're taking with the Pomalyst. Pomalyst on its own will often not produce a complete response. And you will often have a very deep response, but you'll still be able to detect a protein. That's not uncommon. It's also, depending again on what you're taking it with, there are people who definitely go into complete remission, MRD negative, but it's not as common as with some of the other modern therapies. You also need to be a bit careful because if you're on one of these monoclonal antibodies, Darzalex or Sarclisa, then they can show up as a monoclonal protein in your blood, which isn't from the myeloma. There are new ways to look at that and distinguish the two, but they're not available except in sort of pretty highly specialized centers today. MRD, minimal residual disease, means that if you look under the microscope, the best you can probably do is about less than 2% myeloma. You're probably going to have a hard time distinguishing from normal. So we started to develop new ways of looking even deeper in the bone marrow when it looks normal under the microscope. And with the best technologies we have today, which are either DNA sequencing, looking for the fingerprint of the myeloma, or measuring the protein itself in very sensitive ways, we can get down to 1 in 100,000 or 1 in a million myeloma cells in the sample. Of course, it has to be a good sample. If it's this very diluted, it may not work properly. But if you have a good marrow sample, and increasingly we'll be able to do this in the blood as well, and then you can look at 1 in 100,000 or 1 in a million cells, and if that comes back negative, we call that minimal residual disease negative. And this has become a bit of a standard now to try and really determine how deep the response is and whether you can stop drugs, whether you need to escalate them. So those are the different things. The newest technology, mass spectrometry, is just being rolled out now in a sort of commercial way. And so it's sort of coming soon, but may not be available to everybody as of today.
No, I think that's helpful answer. Dr. Berdeja, did you have any comments?
The only thing I was gonna comment on is sort of looking at the questions, but for the person that still has a little bit of protein, I have a lot of patients who, like Keith says, for one reason or another, they still have a detectable M protein. It doesn't go to 0, but they've been like that for 5 years. That is good. That is better than someone who gets to MRD negativity and then 6 months later, the disease is coming back. So it's not always, even though we think the deeper remission we get, it does translate to longer duration. That's not the case for everybody. So just because you have a detectable protein doesn't mean that you're actually not doing well.
Terry's asking if mass spectrometry is as accurate. It's actually almost too sensitive in the peripheral blood. In that somebody has MGUS here on the line, the precursor myeloma. About 1 in 5 normal healthy adults using mass spectrometry, you can find a monoclonal protein. So it's actually almost has the problem of being too sensitive. But it's I think some of those studies to say, do you need a bone marrow? Can you do it in the peripheral blood? Are still ongoing. We're not quite there yet in understanding the power of both technologies. I will say that the field is moving very quickly. The science, as usual, is a bit ahead of the clinical practice. So it's the same for all of these new drugs, bispecific CAR T. We're still in the very early days of these. They're getting better each year. We're learning how to use them better every year. So it's an evolution.
I think this is a good time now. We can pivot and talk a little bit about precursor disease. And so we do know that linvoseltamab is a bispecific. It was just recently approved in the relapsed refractory setting. And now it's being looked at in patients that have high-risk smoldering multiple myeloma. So Dr. Berdeja, what were the findings from this particular study? And what does that actually mean for patients that have smoldering myeloma versus high-risk smoldering?
Yeah, so we put smoldering myeloma and MGUS into sort of these precursor conditions, but obviously sort of having smoldering myeloma does make you higher risk than just MGUS to developing active myeloma, which is what we worry about. So just to kind of back up a little bit, smoldering myeloma has traditionally been treated by just monitoring and just kind of watching closely. And if you kind of took everybody with smoldering myeloma, maybe about 10% of patients would progress to active myeloma per year in the first 5 years, and then it would kind of pull back. But now we have sort of certain staging systems or risk stratification systems that allow us to put patients into different risk categories. And so there's a group called high-risk smoldering multiple myeloma, which by definition has a 50% chance of progressing over the next 2 years from diagnosis. And so that's the group of patients that usually is being tested in clinical trials to determine if we can decrease that risk to prevent that myeloma from becoming aggressive, from starting to hurt the body. Patient who has less than that, so a low-risk smoldering myeloma patient would still be the optimal choice is still to monitor that person, because the risk is much less to developing active myeloma. And until we can prove that we can help, again, we're going back to the risk of starting treatment on someone. Until we can prove that we can help and not hurt someone, we traditionally kind of go with the high-risk patients. So just realize that this is only intended for high-risk patients. And so we know that there are 2 drugs, Revlimid and Darzalex, that have been tested and have shown that you can actually delay the progression to active myeloma in high-risk smoldering myeloma patients, with a lot of caveats on the studies. But I think this study that was presented at IMS is actually quite intriguing, because it's using drugs that are not chemotherapy, right? It's an immunotherapy. It's a bispecific antibody that we know is very powerful. And so the question becomes, is this the time when we can eradicate the disease? Can we do something really powerful to try and get rid of it? And that's the reason for this trial. And so they took patients with high-risk smoldering myeloma, gave linvoseltamab, the bispecific antibody, and they showed 100% response rate and 100% MRD negativity at 10 to the minus 6. So very deep responses, which is what you want to see. It was a limited duration, although at 2 years, I'm not sure that's considered limited, but I guess it is. It stops after 2 years. But here is where that issue comes up. What's going to happen in terms of toxicity? So our concern here, of course, is that even more so than with the newly diagnosed myeloma, these are smoldering myeloma patients that may not have received any treatment. Now they're getting these treatments. If you get a lot of infections and a lot of toxicity, that may backfire. So this is early. This is encouraging, but it's still very early. So, but I think it's very promising. These are the kind of therapies I think we'll need. I'm not sure we need 2 years of it.
Yeah, I'd say it's probably one of the most controversial aspects of myeloma discussions today, in terms of whether you should treat people with smoldering myeloma or not. It's actually a very common problem. The group in Iceland have shown that once you're over age 40, the 1 in 200 people has this. I mean, it's very common. So you're going to start treating them with hundreds of thousands of dollars a year infection risk without any evidence yet that you're eradicating the disease. I think this is why it's controversial. I think there are believers that this is the right thing to do. And if you're a completely non-toxic drug that worked 100% of the time, yeah, of course you would do it. But if you're going to cause infection risk and the disease is going to come back anyway, then we have to be very careful and conservative, I think. So there's definitely a split camp decision on this one at the current time. So mainly in clinical trials for the time being.
I agree.
Go ahead, Dr. Berdeja.
I said I agree.
Yeah, it seems like, again, one broad thing we're seeing is this risk versus payoff, and that's something that we're kind of finding common to a lot of these trials here. Shifting gears now to relapse refractory. So we talked about newly diagnosed. We talked a little bit about precursor. Now, for the relapse population, looking at CAR T cell therapies like Carvykti and Abecma, we know that they've improved survival for patients. So one of the challenging things is picking which CAR T cell therapy to choose. And there haven't really been anything that compares either one of them head to head. And so there's actually a real world study, which is slightly different from, again, a full clinical trial here. Dr. Steweart, can you explain what was found in that real world study and how it differs from the clinical trial with Carvykti and Abecma?
Yeah, so the real world study is basically what's happening once the drug's approved and everybody can use it. And what are we learning? Because remember, in clinical trials, you have to be pretty fit, pretty healthy, good kidneys, good blood counts. no history of another cancer. I see somebody asked about having lymphoma. That would often exclude you, having a cancer like that in the past. So they're very selected populations. So when you go into the real world and you start treating all the people that never qualified for a clinical trial, or they're older than people going on the trial, you start to see different results. So this is a big registry across North America, collecting as much data as we can on people who are getting the drug through their routine care through their physician. This compared the two CAR-T products that are out there. Now remember, one of them came before the other, so there was a time when you only had access to one, which is ide-cel from Bristol Myers, and the second one is a Carvykti from Johnson & Johnson. And it compared, I think, I forget the exact numbers, but hundreds of patients who got both and what happened to them in the real world setting. And in the real world setting, we'll come back to the safety and efficacy question again, the theme of today, because for efficacy, it was pretty clear that both in the clinical trial results and confirmed by real world evidence, that Carvykti had a better response rate, probably longer duration of remission. However, it was also more toxic, and there were specific side effects that were quite unique to Carvykti in about 5% of patients. And I'm sure people listening have heard of these before, but essentially it's late neurologic effects that are more prominent with Carvykti than they are with ide-cel. It presumably reflects the fact that Carvykti is a little bit more capable of, it binds more strongly to the cell, so it can kill more of them, but it can also cause a little bit more in terms of side effects. So overall, Carvykti was superior for clinical responses, but did come with a higher risk, which means we probably need to think about personalizing treatment a little bit more. If you're older, if you have other disease problems in your health issues before, you might want to go with the safer one, particularly as you're getting up in years. If you're younger, you've got high-risk disease, you're accepting a little bit more risk, then obviously Carvykti might be your choice. So that's what the real-world evidence is telling us. It's quite useful, actually, because we really need to know what happens in the general population, not just in these highly selected trial patients. I will say just yesterday, the FDA released a report that there's a complication of CAR T cells, and we really hadn't appreciated until we started treating hundreds of patients that we could actually see it, which is a very bad syndrome of diarrhea. And again, this is something that real-world evidence, it didn't really show up in the clinical trials. And it's now showing up just because so many people have been treated, even though it's 1% of patients, it was a bit buried in the smaller trials where there's only 200 or 300 patients in the study. So I'll start. So that was the real-world evidence story, I think, unless Jesus wants to add to it.
Well, we did get a question asking about in vivo CAR T. So can you explain what in vivo CAR T is, and is there anything looking into that?
People are just too sophisticated these days. I'm impressed.
So a regular CAR T is we take the cells out of your body, we engineer them in the lab with a vector that is infects them in a bag in an incubator, and then we take that bag of cells and we give it back to you. What the Terry here in the chat box is asking is, are there studies where you just take the vector and you inject it right into the bloodstream and target it to the right cells, and that lab piece actually happens within the body? Very exciting, because you can do it, you don't have to wait a month, you don't have to send them off to a lab, specialized lab, wait for them to check it all and then send it back to you and wait a month while your myeloma might be getting worse. You could just take it off the shelf and inject it right into the body. It's very early though. The very small phase 1 studies have just started. They look kind of promising, but not quite as promising as the conventional way so far. So very much just in clinical trials, very early clinical trials right now, but perhaps the way of the future.
And I know we'll get a little bit later, we only have about 12 minutes left, but we will talk about some of those phase 1 trials for people who have exhausted some of their bispecific and CAR T cell options. So we'll get to that in a little bit. Before that, though, I do want to go to bispecifics and some of these outstanding questions that we have around them in terms of how long should a patient stay on a bispecific, and can we reduce dosing frequencies and still see benefits? So Dr. Berdeja, can you summarize just the latest research that's looking at these particular questions?
Yeah, so just sort of as a backdrop, all the bispecific antibodies that are currently approved are approved in the relapse refractory setting as continuous therapy, meaning that patients on the trials got them either every week or every other week, depending on the antibody, and that continued until disease progression or intolerance, kind of like we do everything else with myeloma. But as we've been discussing, and as we're starting to see, everybody has anecdotal data that there are patients that come off this treatment because of a toxicity, usually an infection, when they're already in remission, and we find that those patients can actually stay in remission for a long time, even off therapy. So that kind of started sort of the question of whether we need to continue this therapy indefinitely, especially in patients who reach deep responses. And so actually, as part of the initial clinical trials, they started looking at arms, looking at that specifically, trying to decrease the frequency. So the patient starts every week, for example, and then after they achieved a certain response, they can go to every other week, and then sometimes to even every 4 weeks. And so when you look at that, you see two things. One is patients actually do quite well with less frequent dosing. And the other is that you start seeing less infections. So what we saw in the original study was that the infection risk continued to increase as long as the longer the patient was on treatment. It never actually stopped and decreased like you see with some other side effects. But when you started doing things like Dr. Steweart said, giving IVIG and doing all these prophylactic things to prevent infections, but then also starting to decrease the frequency, we started seeing a drop in the infection risk. And so that is the good news. And then that's what one of the studies that was presented at IMS showed, that can be done safely, and it looks like people maintain the response. But I thought what was very interesting was another real world study again, where they actually looked at their patients who were getting bispecifics and had to stop the bispecific, again, for an infection or for whatever reason, the bispecific stopped after the patient had achieved a remission. And there in those patients, I can't remember what it was, but I think it was like 70% of their patients were still in remission 2 years after stopping the bispecific, which tells us that actually, I think we're doing it wrong. And so that's the good news, is that I think we're going to learn how to do this better. And there is a lot of potential that these therapies may not need to continue indefinitely. And I think that's what the gist of these presentations was.
People are tired of me telling this story, but I had one patient who's just had 6 weeks of treatment with one of the bispecifics. He's 3 years in complete remission with no evidence of disease later. Only 6 weeks of treatment. He did have a lot of side effects, which is why he stopped. So there was obviously something hypersensitive about him. But that your question, if you get into a deep remission with these drugs, it's not clear to me you need to keep going.
Yeah.
And I'd be remiss to bring up, I know we're talking about bispecifics, but also just the findings from like the initial CARTITUDE study as well, in terms of how well patients are, just the overall extended like progression-free survival. So do you have any comments on that from like the CAR-T perspective side of things?
Yeah.
Well, I mean, the latest results suggest about a third of patients, and in fact, in a Chinese study, it was like half the patients at 5 years remain free of disease. And I think optimistically, you might say some of these people may be cured. So I think this is one of the reasons that we're willing to accept, particularly if you're late in your disease course, you've had 2 or 3 lines of therapy, or at least 1 or 2, that the risks that come with these therapies are worth taking, because the long-term outcomes are very good.
Yeah. But I think I think that, I mean, that's what CAR-Ts presumably do, right? There was the one and done theory or therapy that you're off therapy for all those years. And so I think that's why, extrapolating to bispecific, it makes sense, right? If you can induce that deep remission with a short duration of treatment, you may not continue to keep giving it, just like with CAR-Ts. So I think, but I agree. I think the long-term data is looking very good for these types of therapies.
And I think we can, that's a good segue in terms of just looking at this heavily pretreated patient population and what's out there for them. So we know that there can be some success with CAR-T and bispecifics, but there's also unfortunate times when they don't work out. And so, Dr. Steweart, can you talk about some of these phase 1, early phase clinical trials where we're looking at some of these additional agents for people who bispecifics or CAR T may not be working for?
Well, I think, as I said earlier, this is a field in evolution. So there are new hundreds of different ways to make bispecifics and to make CAR T therapies. I think an important one that was presented is on the surface of the myeloma cell, there are proteins that stick out like multi-story buildings from the background, and the ones the CAR Ts target today is called BCMA, or B cell maturation antigen. And there are a lot of therapies targeting that particular protein right now. It's just a way of identifying that's a myeloma cell, not a normal cell. There are a couple of other targets on the surface of the cells that are very specific to myeloma. One is called, there's a long name, it took me ages to remember how to say it, GPRC5D. Nobody actually knows what it does. It just happens to be on myeloma cells at high abundance. And there was a CAR T there. There are both talquetamab, which is a bispecific antibody which targets that specific protein. And there now was a presentation at the meeting on a CAR T that does the same thing. And both look very effective. The downside, again, they come with some special side effects. And particularly that protein also turns out to be in your nails, in your mouth and tongue. And so loss of taste, loss of appetite, brittle nails, peeling skin sometimes are some of the side effects. They're quite unpleasant for some patients to deal with. And so, but that's if you failed a BCMA target and you want to move on to the next thing, drugs that target a different protein on the cell surface. And there's a third one which doesn't get a lot of attention, but is coming, called cevostamab, which targets something called FCRH5. We'll test everybody later if they remember those names, but that's a third one where you can imagine you can go from one to the other to the third one, or you can start to mix them up together. And one of the studies was mixing up teclistamab and talquetamab together. That was targeting BCMA, targeting GPRC5D, and you can do that with the two drugs. Or actually now there's a tri-specific antibody which targets them both at the same time. And the idea there is you're sort of doubling down on finding the cells in the first place, but also perhaps reducing the risk of the cells becoming resistant. We've learned that the myeloma cells are, of course, they're smart, they're evolving all the time. And once you get rid of many of them, sometimes some will emerge that just don't have those proteins on their surface. And then you have to switch strategy.
So I think one follow-up question we got from someone listening, if you have, let's say, BCMA CAR T, can you do GPRC5 bispecific after that?
Absolutely. That's the point I was trying to make very poorly, obviously. You can switch from one to the other for sure.
Yeah. And I'll just add to that actually, in fact, in the GPRC5D CAR T study, 50% of those patients had prior BCMA therapies. Most of them were prior BCMA CAR Ts, and the response and duration of response was identical in both groups, those who had prior therapies and those who had not. So yes, both CAR T followed by CAR T or CAR T followed by specific, I think works quite well.
Well, I think that we've gone really far. We've talked about a lot of things, and we only have a little bit of time left. So just want question for both of you is, were there any findings presented that would immediately impact how you manage your patients? And what would your just take-home message be from this, from the findings at IMS?
I don't know. We travel around going to these meetings all the time, so I don't think there was anything that was, in my mind at least, that was revolutionary at this meeting. That we kind of know a little bit about what's coming. And a lot of it is stuff that's not available outside of clinical trials yet, but we see it coming, like bispecifics, the newly diagnosed patients. I would just say to patients, it's a very, as always in the field, very exciting time. People are living longer. We're managing side effects better. Clearly, we're not curing everybody yet, but there are some people who are probably getting cured. So I think hold in there, and every year it goes by, more drugs become available.
Yeah. I still think sort of the inevitable evolution of moving bispecifics and even CAR Ts to the early line settings, especially newly diagnosed patients. I think gonna happen. It's just a question of doing it safely. But I am very impressed by the data.
Well, I want to thank both of you for joining today. Just on behalf of the MMRF, it's great that you shared a lot of your comments and your thoughts and where the future of myeloma treatment is heading and everything. So thank you so much. And for everybody who is tuning in live stream, just thank you for taking time out of your day to watch as well. Lastly, just want to give a thank you to our supporters, AbbVie, Adaptive, Alexion, Bristol Myers Squibb, Cure, Genentech, GSK, Johnson & Johnson, Kite Arcellx, Legend Biotech, Pfizer, Regeneron, and Sanofi for sponsoring this session, as well as the support we get from an educational grant from Janssen Biotech Incorporated, which is administered by Janssen Scientific Affairs, LLC. I know we had a lot of questions, and we try to get through as many as we can, but if you still have additional questions, especially more like patient-related or personal-related, please reach out to our MMRF Patient Navigation Center. They have an excellent group of nurse oncologists there who can really help get to the gist of what you're trying to look for. So that number for the PNC is 1-888-841-6673. So just encourage you to call that if we didn't get to your question today, or if you have any other questions or comments. So again, thank you, everybody. Thank you, Dr. Berdeja, Dr. Steweart, and everybody for tuning in, and hope you have a great rest of your day. Take care.
Thank you.
Thanks.